Hey everyone, we're back with another video, and this is on how to give a focused patient presentation for a surgical patient. And so, why did we make this video? I actually had really held off on making videos like this for a long time because unfortunately, you can't really learn the perfect patient presentation style for your situation from one single centralized online video. The reality is that the right way for you to give a presentation is the way your attendings or your senior residents want you to give it. However, how that usually works out in practice then is that no one will make a central resource because it's not perfect, but then you as medical students frequently don't get either your team doesn't have time or maybe they don't really just go through it in much detail, right? So instead of having a resource that's not perfect but is still pretty good, you usually end up with no resource, and that's worse, I think, than having a resource that maybe doesn't perfectly apply to your situation. So I decided to go ahead and try to make this video and have it be a really good foundation that can be adapted to different clinical scenarios, whether that's multiple surgery rotations or even, I think these ideas, certainly the general SOAP format for these presentations can be adapted to other medical rotations as well. And if I was going to pick, really the advantage of focused surgical presentations is we really like to keep things short and quick. Usually it's just because we're so busy, but that has a byproduct of really emphasizing really clear and focused communication. It helps keep your attendings and residents more engaged and allows you to show off your knowledge and improve your evaluations. So what's the general structure of a patient presentation? And you've probably heard of the basic SOAP format. So that's subjective, objective, assessment, and plan. But in addition, there's two other parts, which I'm just calling the one-liner or the one-line description of your patient, and then the overnight events. And generally, you'll give your presentation starting with this one-line description, going over overnight events, and then going into that classic SOAP format. So we're going to go into each of these parts in a good amount of detail coming up. So first, just talking about the one-liner. This, your residents know a lot, your attendings know a lot, but no matter how smart people are or how much info they have in their head, it's always good to get oriented when you're about to give a patient presentation. So you just want a really quick, succinct one-liner that gives all the key information about that patient. And the key is you want it to be comprehensive, right? You want all the data, but just keep it short. This is just an intro. You have the whole patient presentation to communicate the rest of the important data. So, for example, you might say something like, "This is Mrs. XYZ. She's a 53-year-old female, post-op day 1, following an open cholecystectomy for choledocholithiasis." And so the really key points for surgery is you always want that post-operative day. You want to know what surgery that patient had, and I think it's really helpful to also put in the indication that that surgery was for. Then the next step is to list the interval history or overnight events. And the key here is these are major events that happened since you guys last saw the patient together as a team. So it's not, oh, they maybe had a bad dream last night or, they didn't like dinner. Right? These are really big, significant events. Patients being transferred to higher levels of care, certainly, maybe issues with some of their lines or tubes or drains. But a lot of the times, right, like the default is there's probably not going to be some major overnight events. So it's just fine to lead with no acute events overnight. And these, I think, are some of the hardest data for med students to really get used to kind of figuring out what's important and where do I get this data. If I was giving advice, the best way to find this data is in the Epic or your EMR of choice, but the nursing notes from overnight are often a really great way to get these electronically. And then, of course, talking to the patient and talking to the nurse at bedside during your pre-rounds are also great ways to get this information. All right, so we've given our one-liner and we've covered any overnight events. Now it's time to move into our actual SOAP format. So starting with S, this is subjective. And really, this is just your interview with the patient. So you want to get from the patient what their concerns are, anything they want to bring to the team. So of course, you always want to do that. And then beyond that, depending on the service, there are some key points you always want to hit. And these are some of those things that are really going to vary by service, right? If you're on the renal consult team, you're going to have very different questions than us with general surgery. But for surgery, you always want to talk to people about their pain, whether or not they're passing gas or having bowel movements, how they're tolerating a diet if they have one, if they're having any nausea. You want to make sure they're getting up and ambulating. And then there might be some other miscellaneous things by even surgery service, like incentive spirometry volume on patients with rib fractures, etc. But so I really like to think, if you think of the general timeline of a surgical admission, right? Like you come in, you have surgery one day, right? And so that just involves kind of being cut open, maybe resecting something, reconfiguring something, right? So what happens to the patient after they go into the OR? They're going to have pain, right? And the other new thing they're going to have, usually for abdominal surgeries, they're going to have ileus. If you're not familiar with the term ileus, that's essentially when the pro-inflammatory state of surgery and the manipulation of the bowels, things like that, just slows everything down. They don't work normally. So until those bowels wake up and start peristalsing, your patient starts passing gas and having bowel movements. Until that happens, they're not going to be able to tolerate a diet. And of course, because of that, they won't be able to progress along this timeline to discharge from the hospital, right? So they come in, they have this disruptive OR event that usually leads to pain and ileus. And then once your pain is controlled on just oral medications, and once your ileus has resolved, you're able to eat normally. And of course, you're able to ambulate and kind of take care of your activities of daily living. That's when you're ready for discharge. So that's why we want to keep a really close eye on how the patient's progressing on all these points. And they should definitely be a part of your subjective interview. All right, so remember, SOAP. So we had S, and now we're to O for objective. And this is the biggest section. As you can see, each of these is we're going to talk about on their own. So vitals, I's and O's, or ins and outs, right? What the patient's eating or getting via IV and what they're eliminating with urine or drains or stool. Their physical exam, their medications. I have this in parentheses because this is data that you usually won't say during your presentation, but you definitely should have available and on hand. And any new labs or imaging since you last saw the patient. So like I said, objective, it's the biggest section. It's also the most read the room type section, right? When you're first presenting to your team, they don't know you, you're kind of proving yourself as a medical student, or if maybe the attending's there and all eyes are on you and this is your time to shine, everybody's really paying attention. They want all the data, you just hit them with all this data and it's great. But typically, right, we're rushing through, we have a big 30 patient census in the morning, we've got to get through all these, go to the OR, et cetera, kind of read the room. And if people, if they know you and they trust you that you're usually on top of stuff as a med student, you can start to kind of leave out some of this data that's irrelevant. For example, not going into every normal finding on your physical exam or every normal finding on the labs, et cetera. So as you get more comfortable with your team, you're going to be able to get a better sense of which of this data is most important to present. So err on more at the beginning, and then you'll probably be instinctively or even be asked by your team to dial it down on certain things. But the key is, especially if you're dialing it down and not presenting all the data, you better have all that data available if anyone were to ask you for it. So without further ado, we'll go through each of these parts of the objective data. So first we have vitals. So the key vital signs, you want to know about the patient's temperature. Usually I would want to know about the patient's max temperature overnight and then their current temperature. You want to know their heart rate, so the range, min to max, and then the current heart rate, and then their quality as well. So if they're an AFib and it's irregular, you want to note that. Otherwise, you can just say regular. Respiratory rate, this is usually less important. If it's high, you can give a little bit more data, but you can usually just get away with one number, respiratory rate of 16 or whatever it is, because unless the patient's having some sort of hypoxic issue, that's usually not a huge concern for the morning decision-making. For blood pressure, once again, just like heart rate, you want the range and their current blood pressure. And then for their O2 saturations, you want to both list what they're satting, so 92%, 98%, whatever it is. And then you want to list what type of support they're on. So most common, they're on room air, so 98% on room air might be an example. Or you want to talk about 2 liters of oxymask, 2 liters of nasal cannula, etc. So for example, if you had a sample patient here, you might say Tmax was 37.5, heart rate ranged from 80 to 110, it's currently 90 and it's regular, respiratory rate of 20, blood pressure is ranging from 110 to 140, over 80 to 90, currently 120 over 85, and satting 98% on room air. As you probably noticed from my shorthand, if I'm writing a range and then I put something in parentheses, that number in parentheses is just the current or their most recent value. Yeah, I think that's the only shorthand I use here. You'll develop your own shorthand, but just keep it consistent. So we're still within our O objectives, remember? Objective data, so here are I's and O's, or ins and outs. These are really important for surgery patients, so you definitely want to know the total I's and O's. as well as their net balance for the day. And we'll go through examples of all of these on the next page. You want to know their urine output by shift. So each shift is 8 hours, right? And that's usually how it's shown in the EMR. And then you usually want the rate so you can prove that they're having adequate urine output. You want to report if they're having any bowel movements, any emesis, if they're taking in any PO intake, it's good to know how much. And then if they have any tubes or drains, chest tubes, JP drains in the abdomen, NG tubes, etc., you definitely want to report those as well. And usually with the tubes and drains, you want to report that in contrast to the previous day so they know if it's increasing, decreasing, staying the same, etc. So once again, blasting through a quick example. So if I was presenting this, I might say something like, for eyes and nose, the patient's up 500 cc's from yesterday with total ins of 2,000 cc's and outs 1,500. Urine output was adequate. They're putting out 30 cc's per hour and had 400 cc's out in the last shift. They had a bowel movement yesterday. They're taking in good PO. They took in 1.5 liters, and their abdominal JP is still putting out serosanguinous fluid, put out 50 cc's today. All right, so physical exam. I think the easiest thing to forget as a medical student is lines, tubes, and drains, or the traditional acronym is LDA, lines, drains, airways. And then just do a head-to-toe, but basic exam. So this isn't a new patient. This isn't a consult, right? This is a post-op patient that you're just following, so we have a pretty good sense of what's going on. For me, I'd really focus on neuro, which is mostly just if they're alert and oriented. The cardiorespiratory exam, listening to heart and breath sounds, checking the heart rate. Of course, an abdominal exam with primarily palpation. And then wound is a big one. This is, of course, unique to surgical services. You usually won't be changing dressing. So instead of reporting on the wound, you'll usually be reporting on the dressing. Is it clean? Is it dry? Is it intact? Etc. And then just a quick look at the extremities, have them wiggle their toes, check their pulses, things like that. And your different residents will want different sorts of data, so you can just adapt. But this is a pretty reasonable start for your basic surgery patient. So another example here, you might say, for this patient, neuro, they're alert and oriented ×4. For cardiovascular, they have regular rate and rhythm. Pulmonary, their lungs are clear to auscultation bilaterally. Their abdomen soft, it's non-distended. They should say non-tender. Their wound, their dressing's clean, dry, and intact. Their extremities are warm, well perfused, and they have intact motor and sensation. And then I just put a bunch of potential examples under LDA here because you want to describe both the drain or the tube as well as what's coming out of it. So for example, they might have an NG tube with thin brown output. They might have a chest tube with serosanguinous fluid and no air leak, abdominal JP drain with frank blood in it. Their Foley in place with clear yellow urine in the bag, or a tracheostomy in place, for example. All right, still an objective. I told you this was the biggest section. And I have, once again, the medications. You just need this data. You usually won't read it out, but it's really good to have available. And in particular, it will help you get a sense of maybe what needs to happen in the plan, right? Because if you're saying, oh, their pain's not controlled, but if you don't know what their pain regimen is, how will you know what to suggest to change? So really good to usually write this down somewhere where you're keeping the data for your presentation. And I'd encourage you to look at both their hospital meds and their home meds, because, and this is what I see with interns all the time, is they forget to check the patient's home meds. And then we get behind not restarting their antihypertensives or whatnot when they're able to take oral intake. So if you can keep track of that as a medical student, it can be quite helpful. All right, still going, still an objective. So labs, common post-op daily labs will be like a BMP. You're probably used to seeing the fishbone diagram, something like this. Sodium, potassium, creatinine, etc. CBC, which is typically demarcated like this, where we have white blood count, hemoglobin, hematocrit, and platelets. And then mag-phos will usually fall on this side of the diagram. I believe it's calcium mag-phos traditionally. The biggest thing I want to tell you with lab values, this was drilled into my head as a med student, never report a lab value in isolation, right? You always have to put it as compared to the previous day's value, especially in surgery patients. Surgery will typically cause a perturbation in the lab values, right? So just because a white count is 15, in this first case, oh, well, their white count went up to 20 post-ops, now it's coming down, and 15 is a good sign. Whereas if their previous day's white count was 8 and now it's 15, now we're a little bit worried. Is there some sort of infection brewing that we need to deal with? Obviously, hemoglobin's another big one. If the previous day's was 12 and now it's down to 9, that is a very big deal, even though 9 is technically not below our transfusion threshold, that is a big drop. Whereas if it was already 9 post-op and now it's 8.5, that would not be much of a cause for concern. So any key lab value that you're reporting, make sure you know the previous day's value. Creatinine is another big one for that too, for example. All right, so for example, you might say for their labs on their BMP, their creatinine is stable. It's 0.8 from 0.9 yesterday. Potassium's low. It's down to 3 from 3.6. White blood count's down to 12 from 16, and their hemoglobin is stable at 12.4 from 12.2. A lot of times, labs might not be available yet. If so, just a quick labs are pending. And you should have a sense of which labs are pending, but that's all you have to say. All right, the last part of objective imaging. So this is pretty rare. The most common would be services like thoracic or cardiac, where you might get a daily chest x-ray. Otherwise, if they have imaging, it's usually because something significant happened overnight. Maybe they got an emergency CT scan or something like that. So you usually won't be needing these in your presentation, but you should always look and see if there's any new imaging. And if there is, try to look at it with your own eyes if you can, as well as report the read if it's available. All right, so just to go back to our drawing board. So we started with our one-line description of our patient. Then we went into our overnight events. We reported the patient's subjective data as well as the objective data. Now we're in our last step of the SOAP format, that assessment and plan. So this was all about gathering data, and now it's really time to showcase your clinical reasoning. So what does it consist of? First, once again, we have that same one-liner from before. As you're probably feeling at this time in the video, right? There's been a ton of data. It's good to go back and orient everybody about who this patient is and why they're here before we start trying to integrate that data that you just presented into a coherent plan for them. And then plan, I wanted to spend a little bit of time talking about this because this is kind of the great debate in patient presentations in medicine is, do you give a plan by system or by problem? And what that means is a system-based plan is like you're based on body system. So a section might be neuro, and then a section below that might be cardiovascular, and then respiratory, etc. Whereas a problem-based plan is literally just based on problem. So they're here for a hypertensive emergency. So hypertension is a problem, but they also have diabetes. So diabetes is a problem. And then underneath that, you're listing out the different parts of your plan for the hypertension, for the diabetes. As a med student, I learned primarily with system-based, and I still think this is the best way for med students to learn because it's a bounded list, right? So there's always neuro down through usually prophylaxis, right? But there's only so many categories you can have, whereas the problem-based they could be here for one problem, or they could be here with 16 problems. And how do you know which problems to put in or not put in, if they're chronic and stable, etc.? I find that much more confusing and leaves a lot of unknowns in my head. So as a med student, especially when you're first learning, I think having a systematic approach by just body system can be a lot easier to deal with. But of course, like I said at the beginning, this really just depends on what your attendings and residents want. You'll be able to adopt this to what they need. So we're going to talk about a systems-based assessment plan in this video. So once again, we have our same one-liner. I usually like to add a little bit of that true assessment to this. Typically, if you can imagine like a consult patient you're seeing with your assessment, you might say part of your one-liner is what you think they're suffering from. But in a post-op patient, right, we know what's going on. We know they're here post-op and they're on the post-op course. So really, your assessment is more, are they doing well? Are they following that basic progression from OR to discharge? Or is something are they suffering from something unusual that's put them off that course? And then we go into the meat of your assessment and plan. So once again, this is just my example of what a system-based plan might look like. With the systems listed, and then in parentheses, I have some very common surgical problems that we deal with in the different systems. And the key is this is not the only system list. You can put in things or take things out. For example, hematology, some people stick in there. I prefer to talk about my anemia and cardiovascular just because I usually don't need a whole section for hematology. If your patient, for example, has diabetes and you're dealing with insulin orders, you might put that under FENGI. Or if you're on the endocrine consult service, endocrine is probably going to be a whole system that you want to incorporate in your list. So the categories don't so much matter as long as you cover all of the basics or all the problems your patients have within these categories. And some of these, even that I've listed here, are rarely useful. So the ones that you'll almost always be using for surgery, you'll have neuro, which are primarily going to be talking about their patient's pain control regimen. HENT is rarely an issue for general surgery at least. You should always talk about respiratory, but hopefully you're not dealing with anything there. Cardiovascular, you're usually talking about, at the very least, some postoperative anemia from blood loss. Of course, the patient's diet is huge in their ileus. So that's going to be dealt with in this section, which is fluids, electrolytes, nutrition / GI. GU and renal, you're mainly talking about urine output. Extremities is rarely needed. Prophylaxis is a big one. All surgery patients have an inflammatory event, which usually makes them hypercoagulable. So everybody gets DVT prophylaxis. I notice a lot of smart phrases will have GI prophylaxis kind of auto-populated in there. That's really not a thing except for very sick certain ICU patients. So really the only prophylaxis you should be thinking of for your typical surgery patient is DVT prophylaxis. And then finally, disposition is a big one, of course, for every patient. Where are they in the hospital? Are they in the ICU or the IMC, Gen Care? If they're in one of them, do they need to go to another? Or if they're in Gen Care and doing well, are they ready to go home or home with home health or discharged to rehab, etc.? So here, once again, just a quick example to run through a quick plan. Neuro, patient's pain is well controlled on their current regimen of Tylenol and oxycodone. Respiratory, siding well in room air. Continue to monitor, encourage incentive spirometry. This is huge. If you don't have anything to use for your plan, just say continue to monitor. That's pretty much a good catch-all. You don't have to have a plan for every system. CV, their post-op anemia is stable. The hemoglobin's 11 from 11.2. They did have some hypertension overnight, so restart their home hypertension medication, carvedilol in this case. Referee and GI, replete their potassium with 40 milliequivalents PO, advance to general diet, turn off IV fluids. For GU renal, their urine output was adequate. We'll continue to monitor. Their AKI resolved. Creatinine's now 0.9 from 1.3. For prophylaxis, they're on subcutaneous heparin. Usually they're on SCDs too, the little leg ankle squeezers. For disposition, their general care, likely home tomorrow if tolerated diet. All right, so once again, we've been through everything now. So back to our full roadmap. We gave a one-line description to get everyone on the same page. We talked about any important overnight events. Then we talked about our subjective data, objective data, and then put that all together into our assessment of how the patient's doing, and then our plan for how we should proceed with the patient's care for the day. And so that probably sounded like a ton of data and really intimidating. Really, I think that's because I just tried to go through all that very comprehensively and talk about a bunch of little minutia. But just to give you an example, on the next slide, I'll show you a real handwritten note of mine. I should say it's really handwritten. It's not real patient data. I just made up some patient data and wrote it out just the way I used to as a medical student. And I'll kind of go first, just show you how much data you can fit in a very small space. And then we'll go through exactly how I would have presented that as a medical student, just to give you an example of how this can actually go into practice. Of course, if you don't need an example, just stop the video now. You've got all the important data. All right, so if I was a medical student, this is how I would present this patient. So this is patient Smith in room 105. She's a 53-year-old female. She's postoperative day 2, sets post an open cholecystectomy for choledocholithiasis. She's doing well today. So overnight, there were no acute events. For subjective, her pain is well controlled on her current oral regimen. She is passing gas and had a bowel movement yesterday. She's tolerating her full liquid diet well. She ambulated 3 times, and she is feeling good and asking about discharge. So for vital signs, her temperature is normal. It's 37 with a Tmax of 37.5 overnight. Her heart rate ranged from 70 to 90. It's currently 80. Her respiratory rate is 20. Her blood pressure ranged from 110 to 140 over 70 to 85. It's currently 120 over 90, and she's satting 98% on room air. For eyes and nose, total ins were 2.5 liters. Total out was 2 liters. So she's 500 cc's positive for the day. Urine output by shift was 300, 400, 350 for a rate of 44 cc's per hour, which is adequate. She had 1 bowel movement, and she took in 1.5 liters of PO intake. Her JP drain is still putting out serosanguinous fluid. It put out 40 cc's for the day. For physical exam, she's alert and oriented ×4. Her heart sounds are normal. Her lungs are clear bilaterally. Her abdomen is soft, non-distended, non-tender. Her wound, I did not take down the dressing, but the dressing is clean, dried, and intact. Her extremities are warm and well perfused, and her drain is still serosanguinous. For labs for BMP, her creatinine is improving. It's 0.9 today, down from 1.3. Otherwise, her BMP is grossly normal. She does have some decreased magnesium of 1.2. For her CBC, her white count is downtrending to 14 from 18 yesterday. Her hemoglobin is roughly stable, 9.9 from 9.5, and platelets are roughly stable as well, 200 from 243. For imaging, there was no new imaging overnight. So for assessment and plan, Mrs. Smith is a 53-year-old female. She's post-op day 2, status post-open cholecystectomy for choledocholithiasis. She's doing well. For her plan today, for neuro, her pain is well controlled, so I'm not going to change her current regimen, which is Tylenol 1000 TID, as well as Oxy 5 to 10 Q4 hours PRN. For respiratory, we'll just continue to monitor. Cardiovascular, her post-op anemia is stable. We'll continue to monitor that with daily labs while she's admitted. For hypertension, we'll continue her home co-reg. It's currently well controlled. FENGI, she does have hypomagnesemia. We'll replete that with 4 ml equivalents IV. For diet, we'll advance to general. And for baseline GERD, we'll continue the home PPI. For renal, she's got good urine output, so we'll just continue to monitor there. And for prophylaxis, we'll continue DVT prophylaxis with sub-Q heparin, 5,000 TID. And for disposition, right now, she can stay general care, but I think she's actually going to be ready to go home today if she tolerates her general diet. All right, so that's it. Hopefully that was a helpful example to put what we just talked about into practice. Just really see as many patients as you can, get used to writing this data. It will get much faster and easier with practice, just like anything else. I hope this was useful. We can do more examples, videos like this on how to actually do some of these fundamental medical student skills that so many people talk about. For example, different types of notes, if there's interest. But like I said, I was a little bit nervous about doing this video because there's no one right way to do this. This is a right way, but the right way for you is the way your senior residents want it done. So hopefully this can give you some good background, some foundation to review, and just tweak for however would work best for your circumstances. All right, that's it. These videos are for educational purposes only. Do not use them to diagnose or treat any disease, and we'll see you next time.